Hello, welcome friends. Welcome to yet another episode of Need PG Concepts, and I am your host, Dr. Shadab Jafri. Now, friends, today I am going to deal another important topic, which is very important for your entrance examination. Multiple MCQs will come. We have dealt with arrhythmias, mostly supraventricular tachycardias, in our previous videos, and continuing with that, today we'll do an integrated session on the physiology, medicine, pharmacology regarding the concept of antiarrhythmic drugs with action on different cardiac tissues such as the ventricular muscles, the atrial muscles, the atria, the conducting system of the heart, and various clinical scenarios in which those drugs will be useful. So it is going to be a very useful session. Please stay tuned. Now, these two figures you must have definitely seen in your physiology or the pharmacology textbooks, and these figures are often the base of the question which are asked in the competitive entrance examination because these are the very important for understanding the mechanism of action of the antiarrhythmic drugs as well as the cardiac physiology, which will lead to different clinical scenarios and different management according to the scenarios which are going to arise. Now you see the first figure, that is the pacemaker potential, and the second figure, which is mostly seen in the ventricular muscle fibers. Now these two are important. Other also in the AV node or in the Purkinje fibers, the figures are given in your textbook. But these two figures you have to concentrate mainly on these two figures. The first one is known as the pacemaker potential, and the second is known as the ventricular action potential. Now first we'll deal the ventricular action potential. What is it? Now you will see that the first part which is given in the red, that is the phase, that is the fourth phase. And after that, the zero phase, that is the start of the ventricular depolarization. Now, as the impulse comes, the sodium channels they open, and the sodium influx is there in the inside the cardiac myocytes, and it leads to a rapid depolarization phase, which is shown in the green in the second figure. Now, after that, there is slight decline. That is the slow inactivation of the sodium channels, which is slight decline in the action potential. And then comes the phase shown in the blue. That phase is due to the influx of the calcium, which is the Plato phase. And then comes the opening of the potassium channels, and the potassium comes out of the cardiac myocytes, and that leads to a repolarization phase. Now that is which is shown in the red. Now the time which is the shown the time period between the green line and the red line at the base, that is known as the effective refractory period, which is also affected by various drugs which we'll see in the future. Now you see the first figure, which is the pacemaker potential, which is seen in the SA node. As the impulse comes to the SA node, the cells which are discharging, they they have the hyperpolarization and hyperpolarization. Now one thing is very important for you to see that the action potential in the SA node is mainly found by the calcium channels due to the influx of the calcium channels, and in the depolarization of the ventricular muscles, the sodium channel influx is mainly responsible. So these two differences you have to keep in mind. Now, with this physiology in the mind, we are going with onto the pharmacology. Now, you see this figure you must have seen in your pharmacology textbooks. Now, this is primarily the ventricular muscle action potential and how these antiarrhythmics, which are four types, which are classified according to the channel which they block. The class one, they primarily block the sodium channels. Class 2 are the beta blockers, class 3 are the potassium channel blockers, and class 4 are the calcium channel blockers. Now, in this figure, you see that class 1 is divided into class 1A, B, and C, and class 1 drugs, all the class 1 drugs are acting on the sodium channels. And there's one more important property whether they are uh, increasing or decreasing the effective refractive period. Now, you see the class 1A drugs, the class 1 group 1A drugs, they are increasing the effective refractive period. The class C drugs do not have any action on the ERP, and class 1B drugs are decreasing the effective refractive period. And these will be very important when we deal the different clinical scenarios in which the drugs will be acting. Now, now coming back to our topic. Now we have dealt with physiology and the pharmacology section. Now applying these knowledges of pharmacology and physiology to the medicine part. Now this is very interesting. You must have seen this chart. Now before going to this chart, let's see some of the very important terms and what are those terms. The कि आप ये देखिए आपकी ये जो हमें एंटी एरिथमिक्स हैं ये हमें कहाँ कहाँ पे ये किस तरह से अप्लाई कर सकते हैं। हमने पेसमेकर पोटेंशियल देखा, हमने वेंट्रिकुलर एक्शन पोटेंशियल देखा। अब क्या क्या कुछ टर्म्स हैं। व्हाट इज, सपोज द फर्स्ट टर्म इज एबनॉर्मल ऑटोमेटिसिटी। नाउ एबनॉर्मल, कोई अरिथमिया कैसे स्टार्ट होगी? एबनॉर्मल ऑटोमेटिसिटी किसी तरह के हो जाएगी, कोई पेसमेकर ओरिजिनेट कर जाएगा जो ऐसे नोड को ओवरकम कर लेगा। हमें उसको या तो सप्रेस करना है। अगर हमको उसको सप्रेस करना है तो आपने ऐसे नोड का पेसमेकर पोटेंशियल देखा, वहां पे मोस्टली कैल्शियम इन्फ्लक्स की वजह से पोटेंशियल डिपोलराइजेशन हो रहा है। सो कैल्शियम चैनल ब्लॉकर्स आर, verapamil diazem are most important in those type of cases where the abnormal pacemaker originates. You will see further. If there's abnormal conduction, there like a re-entry in the like Wolff-Parkinson-White syndrome, then also some drugs will be active, will be acting on those things. Now, so these are the things which are very important for you to understand. Now, one thing is the most important, whether the drug is acting on the normal tissue or the drug is acting on the disease or the ischemic heart. Now, the class 1A drug, mostly the class 1A drugs, like the procainamide, they mostly act on the normal tissues. And the class 1B drug, they mostly act on the disease tissue or the ischemic tissue. So they are mostly in the class 1B drugs are mostly used in the setting of acute myocardial infarction. Whereas the class 1A drugs, they are regularly used in the like atrial and ventricular arrhythmias, PSVTs and all. Now you must be seeing that we have talked much about adenosine in our PSVT lectures. Now, why adenosine is used and these drugs are not considered? Because adenosine has very less amount of toxicities, and these drugs like the class 1A, class 1B, and C drugs, these have these have their own limitations. These cannot be used in the heart failure cases, and these are pro-arrhythmic drugs also. Means if you are giving for arrhythmia, they can cause some type of arrhythmias. They can prolong the QT interval. So these drugs have their limitations, but in some settings they can be used. Now, amiodarone is one of the broad spectrum antiarrhythmics you can see, and it is a type 3 agent. Now, this amiodarone, but it also has its limitations. It can cause pulmonary fibrosis and deposits in the cornea, etc. So these things uh, you must consider while treating your patient. And this will be very important remembering the treatment part. Now, in the rate control, as you know, the beta blockers are very important. The propanolol, sotalol, esmolol, these are very important for rate control in cases like atrial fibrillation, and then in any type of arrhythmia originating from, suppose, exercise, exertion, etc. So beta blockers are very important. So now you must be having a brief concept of how you can remember these drugs in clinical situations, in several type of clinical situations. So you can pause the video and look at this chart, enlarge this chart and see. This is given in your pharmacology textbooks. The class 3 agents like amiodarone and dofetilide. The amiodarone is used in the rhythm control in the chronic atrial fibrillation. And dofetilide is used in acute atrial fibrillation not responding to um, like adenosine or other drugs. Now, in the most of the clinical scenarios, most of the questions which are going to be asked in the examination, if the question is, if the diagnosis in the question is the PSVT, then adenosine will be the options, be, uh, will be the option of choice because the adenosine is having very less side effects. And if it is in the setting of acute coronary syndrome, and there is ventricular tachycardia, ventricular arrhythmia is given, then amiodarone will be the option because amiodarone is also having very less amount of toxicity. Only the pulmonary fibrosis and the corneal opacity is one of the toxic manifestation. Otherwise, they don't have the pro-arrhythmic effect. So these are the very basic points. And if the definitive treatment is asked, then always in the setting of acute coronary syndrome, the and the in the choice if ICD is given, then ICD or the implantable cardio water defibrillator will be the option of choice. Now, if in the setting of the supraventricular tachycardias, if the adenosine is not given in the choices, then what? Then you will search for the other choices like the ibutylide and the procainamide, etc. And if in the setting of acute coronary syndrome, the amiodarone is not given, and then you will search for the drugs like lidocaine, and that will be the answer of choice. Now, to summarize once again from the beginning, the first we have wrote down some important points. Now, the myocardial fibers have a resting potential of minus 90. The action potential in the SA node is due to the activation of funny channel because it activates Pauling hyperpolarization and it conducts both sodium and the potassium. Now, current produced by the funny channels is called funny current, and as the current increases, membrane depolarizes from the first part of the prepotential. And the parasympathetic stimulation decreases the slope of prepotential, and the sympathetic stimulation increases the slope of those prepotentials. Now, action potential in the SA node and AV node is mainly due to the calcium influx, whereas the depolarization is mainly due to the calcium influx, and no role of the sodium is there. Whereas in the ventricular muscle, the depolarization is mainly due to the sodium channel, sodium influx. Now, there are latent pacemakers present in the conducting system. Now, which when they overcome the SA node and AV node, or when when the SA node is depressed or the conduction is blocked, then these latent pacemakers they overtake the SA node. Amiodarone is a broad spectrum antiarrhythmic, which is very often used, and the ventricular muscle discharges spontaneously only when diseased. And the class 1B drugs are useful mostly for the ischemic myocardium. Now, I have summarized all these points, and in the next video, I'll deal with some very important MCQs based on these concepts. So, until then, goodbye. Please do like and subscribe our channels. We are working very hard in our endeavor. Please support us.